Professor Technologies Dr. Salmia Kasolang, Rector University Teknologi Mara, Cawangan Pulau Pinang, Associate Professor Insinyur Dr. Ahmad Rashidi Razali, Deputy Rector Academic Affairs and Internalisation, University Teknologi Mara, Cawangan Pulau Pinang, Associate Professor Dr. Hashim Fazil Arifin, Head of Academic Centre, Faculty of Hotel and Tourism Management, University Teknologi Mara, Cawangan Pulau Pinang, Professors, Associate Professors, Doctors, lecturers, and all audiences. Welcome to the International Webinar on Food Safety Research, Applications to Consumers and Food Service Operators. Assalamualaikum and good morning. This international webinar is jointly organized by Faculty of Hotel and Tourism Management, University Teknologi Mara, Cawangan Pulau Pinang, with Department of Dietetics, Faculty of Medicine and Health Sciences, University Putra, Malaysia. This program is now live streaming via YouTube UiTM channel, University Teknologi Mara Cawangan Pulau Pinang official Facebook page, and Facebook Faculty of Medicine and Health Sciences, University Putra, Malaysia. I would like to welcome our second moderator, Dr. Shafiqah Rahmat from Department of Dietetics, Faculty of Medicine and Health Sciences, and all attendees from University Putra, Malaysia.
Assalamualaikum and very good morning to all.
Now I put the cleanser. Nak serap. Macam bayar saya. Ladies and gentlemen, to begin our program, I would like to invite all Muslims attendees to recite our Ummul Kitab Al-Fatihah. Amin, amin, ya Rabbal Alamin. Ladies and gentlemen, without further ado, I would like to invite Yang Berbahagia, Professor Technologies Dr. Salmia Kasolang, Rector, University Teknologi Mara, Cawangan Pulau Pinang, to deliver her speech. Please welcome.
Thank you, moderators, Dr. Nur Hidayah Cik Ahmad from UiTM Cawangan Pulau Pinang, and Dr. Shafiqah Rahmat from UPM. Yang berbahagia Profesor Insinyur Dr. Ahmad Rashidi Razali, Deputy Rector of Academic and International Affairs, University Teknologi Mara, Cawangan Pulau Pinang, Malaysia. Distinguished Speaker, Professor Dr. Susan Woolsdorf Arendt, Iowa State University, United States of America. Deputy Rectors, Heads of Department, University Teknologi Mara, and University Putra, Malaysia. Respective committee members, fellow academicians, participants, ladies and gentlemen. Assalamualaikum warahmatullahi ta'ala wabarakatuh. Alhamdulillahi rabbil alamin. Wassalatu wassalamu ala ashrafil anbiya'i wal mursalin. Wa ala alihi wa sahbihi ajma'in. Alhamdulillah, let us extend sincere gratitude to Allah subhanahu wa ta'ala for giving us the opportunity to be here today in international, right? There is some distraction there. For giving us the opportunity to be here today in international webinar on food safety research, application to consumers and food service operators. Let me start by congratulating everyone involved in this webinar wholeheartedly. Well done, all of you. I would like to go on by saying that it is a great honor to deliver my opening speech for this webinar. This effort is one of these Rector's special project to get in touch with our alma mater, and it is a form of strategic alliance that brings synergistic benefits to all parties involved, in line with the mission and aspiration of UiTM to become a globally renowned university. So we had a few months back a workshop where we called all our staff who did their study abroad. And we had a discussion to come up with a strategic action to ensure that we will get our mission, that is to become globally renowned university. So I'm truly happy that everyone is giving the utmost commitment to realize all the efforts and programs planned. Um, I just want to tell the audience that it is the national agenda to send our students and also our staff abroad to get their study abroad. One of the reasons is so that they will come up and help the country moving forward. And I myself, I was sent to University of Wisconsin, Madison, around 1990s, and I did my bachelor there. So I'm so happy that I did my bachelor at the University of Wisconsin, Madison, and this has been a program since many years. Yeah, and we are also fortunate to have our speaker, Professor Dr. Susan Wolsdorf Aaron. She's a professor and also university faculty fellow for online learning at Iowa State University, where she has been serving for 15 years. Thank you so much, Prof. Aaron, and we are very grateful to have you with us today in this webinar. And I think this is only the beginning for many more to come, many more collaboration. I sincerely hope that this webinar will forge a productive and positive long-term relationship between the three universities, Iowa State University, UITM, also UPM, and open up a window to a better understanding of our different cultures, and we can share so many things uh, between these three universities. And I'm also an alumni of UPM, University Putra Malaysia. I did my master's actually in UPM. So without doubt, this webinar is a good global collaboration project of the higher learning institution, where we put all our efforts, enthusiasm, and energy. We will further witness more successful joint effort programs and fruitful sharing session between or among the educators of the university and higher education institution globally in the future. Finally, I would like to express my gratitude to Dr. Noor Hidayah Sheikh Ahmad, as well as to all the committee members who have been very committed in making this webinar a success. And congratulations, Dr. Hidayah, because this is the first mini action. This is the first program after that workshop. Yeah, so congratulations. We have one program going on. I would also like to thank all the participants for your presence. We are really grateful to have all of you here and your continued support towards such programs. I strongly believe that with continuous support and commitment from all of us, Malaysia's higher education will continue to grow and become stronger. Before I end my speech with great pride, I would say Bismillahirrahmanirrahim. I now declare the international webinar on food safety research application to consumers and food service operators officially open. Thank you so much.
Thanks to our beloved rector, Yang Berbahagia, Professor Technologist Dr. Salmia Kasolang, for her opening speech. Ladies and gentlemen, today we are blessed to have Professor Dr. Susan Wolsdorf Aaron from Iowa State University, United States of America, as our speaker. But before we invite her, I would like to present a brief introduction video. Now, please welcome Professor Dr. Susan Wostorff-Arendt to deliver her talk. To all attendees, if you have any questions related to today's webinar, feel free to post on the chat box. Please welcome Prof. Arendt.
Thank you. I'm going to go ahead and share my screen now. Are you seeing my screen? Thank you, Dr. Kesselong, for those opening remarks. Thank you to the Faculty of Hotel and Tourism Management, University Technology, Mara, and Department of Dietetic Faculty of Medicine and Health Science, University Putra, for jointly organizing this webinar today. Thank you for this kind invitation to be with you here today. While it is after 9 p.m. at night here, I'm excited to be with you. I will tell you that this is not my optimal time of day. As I was telling some of the organizers a few minutes ago, I tend to like the 5 a.m. time better than the 9 p.m. time. But I am nevertheless thrilled to be with you. It's been about 9 years ago now since I was in Malaysia, and I have two pictures on this slide. The picture on the left represents my memories of flying into the Kuala Lumpur airport about 9 years ago. I remember seeing all the beautiful palm trees out the airplane window as I started to land, and I thought this must be a beautiful place. Now, the picture on the right is what you would see here in Iowa. Rather than palm trees, we have lots and lots of corn plants. These corn plants produce corn that is used to feed livestock like cattle and pigs. In total, we have about 87,000 farms in Iowa. Well, this is the outline I will follow for our webinar today. First, I will give a brief introduction and some information about my university, Iowa State University. Next, we will go over the objectives for this webinar. Then I'll review terminology that I will be using throughout the webinar. I'll provide rationale for why it is important to do research related to food safety. After that, I will present 5 large food safety research projects where I have been a member of the research team. All of these research projects are considered applied research, whereby we gather data and then use those data to develop solutions. You see the project names for each research project on the slide. I will present the titles again when I talk about each project later on. So who knows where Iowa State University is located? I know some of you are Iowa State University graduates, and we also heard that someone went to the University of Wisconsin, which is not too far from Iowa State University. I want to welcome all of you fellow Cyclones to this webinar. Well, Iowa State University is located in the United States, and we're in Iowa, which is a Midwestern state. Iowa State University is one of 3 state universities in Iowa. We are located in what is called the heartland of the United States. Now that you know where we are located, I will tell you more about our university. Iowa State University was founded in 1858, so our university is about 163 years old. Therefore, we have a long history and many traditions. The picture on this slide is of our beautiful campus pond and two swans. Their names are Lancelot and Elaine. Currently, we have more than 31,000 students. We have 7 colleges, and I am in the College of Human Sciences. My department is called the Department of Apparel, Events, and Hospitality Management. I also have an appointment in the Food Science and Human Nutrition Department. We have undergraduate and graduate programs in our department, and these programs are listed on the slide. So that has been my very brief introduction to Iowa State University and where I work. Now I will review the objectives for this webinar and our time together. The first objective is to understand why it is important to do research about food safety. Second, I'll define the scope of applied research where I have been part of the research team. I will be doing this by presenting those 5 different research projects I mentioned before. And the third objective will be to determine linkages between food safety research studies and outcomes for food service employees, food service operators, and consumers. I know we have many different groups in our audience today, including lecturers, teachers, students, researchers, and individuals from the industry. So my goal is to present relevant information to all in the audience. I want to make sure that we have a understanding of some terms that I'll be using throughout this webinar. I'll quickly review some terminology. First, food safety is preventing contamination during handling, preparing, and storing food. Food safety practices are taking steps to avoid contamination of food. These include proper hand washing, holding food at correct temperatures, and avoiding raw food contact with cooked foods. Food poisoning is illness caused by bacteria, virus, or parasites that contaminate the food. Food poisoning is also called foodborne illness. So if I slip up and use that term, I mean food poisoning. Symptoms of food poisoning include diarrhea, nausea, vomiting, and others. An outbreak is when 2 or more people get sick from the same contaminated food. In contrast, a case is where only 1 person becomes sick from food poisoning. A couple additional terms. Applied research refers to research where data are gathered, analyzed, and then used to develop practical solutions. And I think you'll see as I go through the research projects how we have collected data and then used those data to develop practical solutions, in many cases for industry or for consumers. Food service is any operation that serves food. There are 2 food service types that I'll talk about: non-commercial and commercial. Non-commercial food services are generally not for-profit operations, like a food service in a hospital or in a school or at a university. Commercial food service, on the other hand, usually refers to those for-profit operations, like restaurants and coffee shops. I'm going to go through a bit of background about food poisoning before we get into the research studies. There are many different causes of food poisoning. and many way foods can become contaminated. For purposes of this webinar, I am referring to the unintentional contamination of food rather than the deliberate act in contaminating food. Therefore, I will not be addressing food defense, which is protecting food from purposeful acts of contamination. Some common unintentional contaminants are those bacteria and viruses listed on the slide: Salmonella, Listeria monocytogenes, norovirus, and E. coli. We know that food handlers, or those that touch food to prepare it, can be carriers of these contaminants. Oh, I'm going to go back. Okay, so the picture on this slide I just wanted to mention is representative of the microorganisms in a petri dish found on a person's hand after using the restroom and not washing their hands afterwards. So again, an illustration of contamination. Okay, some common causes of food poisoning. There are many causes of food poisoning, and this slide indicates some of the most common ones. The first one being time and temperature abuse. Examples of this might include leaving foods out at room temperature rather than refrigerating them, or not cooking food to a high enough temperature to kill bacteria like Salmonella. The second one, infected food handlers. Pathogens like norovirus can be transmitted from someone handling food with dirty hands, transmitting to the food. These pathogens are often transmitted on a person's hands. Hygiene practices not being followed is another common cause of food poisoning. If pathogens are present on a person's hands, proper hygienic practices can help mitigate the spread of these pathogens. This is why proper hand washing is so important. The fourth one, improper cleaning and sanitizing of food preparation surfaces and equipment. Cleaning is the act of removing dirt, while sanitizing is reducing the number of pathogens. Both are important. The fifth one is contaminated raw food. Even before food gets to the consumer or to the food service operation, it can already be contaminated. Many food poisoning outbreaks have been linked to contaminated raw product such as cucumbers, melons, and leafy greens. So what can consumers do to prevent food poisoning? Here is some general guidance for consumers. And I think we need to recognize that all of us are consumers. First, buy food from a reputable source or a store that has a good reputation. Keep hot food hot and cold food cold. For example, after purchasing foods such as meat, fish, poultry, or tofu, these should be put into the refrigerator as soon as possible. Use proper hand washing procedures. Using hot water and soap while vigorously rubbing can help in preventing cross-contamination. Lastly, keep raw foods away from cooked foods. The poster on this slide represents these concepts and reminds consumers very simply of these four principles: clean, separate, chill, and cook. Well, what about food service operations? How can food service operations and employees prevent food poisoning? You're going to see and hear, as I talk about this slide, that many of those preventative measures that I addressed on the consumer end also apply for food service operations and employees. Employees should not come to work when they are sick. Food service operators and managers should purchase food from reputable sources. This means that they should purchase food from a supplier that has safety measures in place. For example, the supplier should transport food in a refrigerated unit if the food is to be kept cold. This could include beef, chicken, or lamb meat. Avoid cross-contamination. One way to do this is to use separate cutting boards for meat and a different one for raw vegetables. That's what the picture on this slide represents. It shows different colored cutting boards that can be used to help prevent cross-contamination. For example, the red board might be used for meat, the yellow board might be used for poultry, and so on. Avoiding time temperature abuse is another preventative measure. By cooking food to proper temperatures and holding food at proper temperatures, we can help to mitigate the risk of food poisoning. And lastly, following those good personal hygienic practices like washing hands properly. You'll hear me talk about hand washing many times throughout our webinar today. Well, food safety is certainly a global issue. Food poisoning outbreaks have been reported all over the world. Foods such as seaweed, chicken, fresh produce like cucumbers and lettuce, as well as cooked products like custards and puddings have all been implicated in food poisoning outbreaks. Although each country has a different mechanism to identify and then investigate food poisoning cases and outbreaks, the goal for all is to decrease overall food poisoning incidents to keep people safe and healthy. Here is just one example of a recent outbreak that we've had here in the United States. This is an example of a raw food contamination. The food was raw onions, specifically red onions, and Salmonella was the bacteria identified. Salmonella can be found in contaminated dirt and water, so it's likely that these onions were contaminated while growing. The red onions were then harvested with other types of onions, yellow and white onions, and the onions that the red onions contaminated both the yellow and white onions. The onions were not only sold raw, they were also used in prepared products like pizza and salads. So you can see the potential food products that had to be removed from the market and could not be sold to consumers once this outbreak was determined. In researching about Malaysia and recent food poisoning outbreaks, I found that in 2020, there was a group of teachers who became sick while at a training. The suspected food in that outbreak was cooked chicken. So again, recognizing that food safety is a global concern. Food safety is also relevant for all of us. As I said, we're all consumers. We want to mitigate or decrease our own risk of getting food poisoning, and we want to teach others how to decrease their own risk. I have 2 daughters, and one of the first things I taught them when they were young was about hand washing. I would not let them into the kitchen to help me prepare meals until they had washed their hands. I never knew where those hands had been. Now, as a food service operator and employee, it's important to keep customers safe. It does not matter what type of operation, whether it be a commercial or non-commercial food service, the goal is to keep customers safe and healthy. As a healthcare professional, our goal is always to help patients remain healthy or to become healthier. Food poisoning can have long-lasting and devastating consequences, such as renal failure, kidney failure, and even death. Therefore, part of the role of healthcare professionals is to educate patients on safe food handling, and also for those healthcare professionals to diagnose when food poisoning has occurred. One of my research projects that I will be discussing is specifically about healthcare professionals. Here's a bit of background on food poisoning in the United States. We estimate that about 48 million people get sick each year from food they ate that was contaminated. The reason these are estimates is because not everyone will report when they get food poisoning, so the numbers are solely estimates. There are about 3,000 deaths each year here in the United States due to food poisoning. The cost of food poisoning is significant. We have cost of food poisoning to consumers, and I'll also talk about the cost of food poisoning to food service operators and employees. Because food poisoning is costly, we want to try and prevent it from happening. The potential cost of food poisoning to consumers, as I said, is great. If these consumers are part of the workforce, they may miss work due to the illness and have lost wages. Depending on the severity, there is possibility of hospitalization and health-related costs. Food poisoning can have long-term effects. Food poisoning from E. coli may cause kidney failure and the need for hemodialysis, resulting in a decreased quality of life. The highest cost is loss of life or death. For those in vulnerable populations like older adults and young children, food poisoning may cause death. Now, the impact of food poisoning on food service operations is also great. If a food poisoning incident is linked to a restaurant, this can be devastating to the business. An outbreak can result in lost revenue and tainted reputation. There may be decreased employee productivity, as employees may be consumed with handling the aftermath of that outbreak. There is the potential of lawsuits where customers who got ill sue the restaurant. In the United States, we have lawyers that specialize in food poisoning litigation. It is not uncommon for a restaurant to close permanently following a confirmed food poisoning outbreak. It's also important to recognize that given the many social media outlets, food service operations may be falsely accused of causing food poisoning. For example, if a customer posts a comment like, "I just ate at Sushi King and I got sick," this can have negative effects on the business. Even though the person who posted believed they got ill from eating at the restaurant, it was not proven yet, but others believed it. This recently happened in our town here in Ames. A customer who ate at one of the locally owned restaurants posted to a public forum that they got ill from eating at that restaurant. Instead of other people posting about how they had eaten at that restaurant and gotten ill, many posted positive comments about the restaurant and rallied in support of the restaurant owners and employees. The restaurant did close for a week to clean and sanitize, and an investigation by the health officials was completed. No outbreak was confirmed, and the restaurant, thankfully, continues to be a successful business in our community. Many times, the ending does not happen that happily. In terms of dollars lost from a food poisoning outbreak, this study by Birch et al. Found that a single food poisoning outbreak resulted in millions of dollars lost, irrespective of restaurant type. Ranges for each restaurant type are provided on the slide, and you can see a large range for each category, from fast food to fine dining restaurants. Well, I don't think we can get through a webinar without talking a little bit about COVID. It's on all of our minds lately, so I want to talk a little bit about how the COVID-19 pandemic has influenced this topic area or influenced food safety. And here are some relevant highlights. In the United States, formal reports of food poisoning have decreased. Okay, this means fewer people are seeing healthcare providers and getting tested for potential food poisoning, or it means that they're just not contacting their local health officials when they have food poisoning symptoms. So the health officials cannot follow through and investigate these further. People have become more aware of the importance of hand washing and how hand washing can help prevent the spread of virus. This is definitely a good thing, and we will hopefully translate this good habit even after the pandemic. As is common in many places, the demand for food delivery and carryout have increased. And many food services do not allow customers into their dining areas or to eat inside. Last, home cooking has increased, and therefore the need for consumers to practice food safety has been elevated in importance. That's all I'll talk about COVID-19 in the rest of the webinar. Okay, with that background in food safety, I will now transition and present the 5 main research projects included in this webinar. I will present these research projects in chronological order, starting with those that are older and working to my more recent research studies. The names of the studies are provided on the slide. After I have presented projects 1 and 2, we will take a 15-minute question and answer session. A second question and answer session will occur after the 5th project has been presented. I want to give a bit of a background regarding these research projects. All of the research projects I am presenting are multi-year projects. The shortest was about 2 years in length, and the longest I put 5+ years, probably 6 years or so. All of the research projects were part of collaborations with other researchers, including other professors here at Iowa State University and other universities. Many graduate students assisted on these projects. And we have also partnered with governmental agencies on some of the projects. You can see a listing of some of these on the slide. All of these projects were externally funded I served as the principal investigator for 3 of the 5 projects. Funding ranged in amount from $20,000 to $500,000 US dollars. As I discuss each research project, I will make application to consumers and food service when it is applicable to do so. Some projects are more focused towards food service operations, and others are more focused to consumers. For this first project, we wanted to assess what motivated employees to handle food safely. Then, after we determined these motivators, we developed training that targeted food service supervisors and managers. We developed the training for supervisors and managers because they are the ones that can provide incentives to help motivate employees in the workplace. This project was funded by the United States Department of Agriculture. So here are the objectives for this first research project I'll be discussing. We had 4 objectives. First, we developed and tested a theoretical model to explain food service employees' motivation for following safe food handling practices. Then we determined employees' perceptions of how their managers and supervisors impact their performance of these food safety practices. Third, we utilized data collected in Objective 1 and 2 and developed a set of training modules on supervision and leadership developed for those managers to improve their skills and abilities to motivate employees to follow safe food handling practices. After we developed the training modules, we then implemented and evaluated the training modules. Okay, a very brief review of literature related to this project. Barriers to following safe food handling behaviors have been identified, including employee motivation. Food safety research has pointed to the significance of having an educated and trained workforce. However, we know that education and training alone do not ensure follow-through by employees. I want to emphasize this point further. Just because an employee is trained and has knowledge about food safety does not mean this knowledge will translate into desired behavior. To illustrate this important point, I always ask my dietetic students in class this question. I ask them, how many of you always wash your hands for 20 seconds with warm water and soap? How many of you, every single time you hand wash, do those things? Less than half of my students raise their hand that they always wash their hands properly. Now, all my students know how to properly wash their hands because they have been certified in food safety. But just because they know it doesn't mean that they always do it. I'm sure we can think of examples in our own lives where we know what to do and why we should do it, but we do not always behave in a manner consistent with our knowledge. Now, we do know that in food service operations, management culture is important in ensuring safe food practices are followed. Leaders, including managers, should be the ones who create, strengthen, and sustain a food safety culture within an organization. Okay, so here is our research model. I think this is the only research model I'll show during the webinar. So this is, for those of you that like research models, this is the one you get here. So here's our research model. It's explaining how a supervisor's role impacts whether employees follow safety practices in the workplace. I will review the 4 areas of influence we are addressing here. First, communication. How and what a supervisor communicates to an employee impacts their food safety practices. The second one, recognition and discipline. Whether a supervisor recognizes an employee for doing a good job with food safety practices or disciplines an employee when they do not follow safe practices has influences on employee motivation. Internal motivators. Now, I will state that all of the other 3 are external motivators, but we also found that employees were internally motivated to follow safe food handling practices. For example, some of the food service employees in schools that were feeding our young children told us that it gave them a good feeling inside to provide school children with a meal that was safe and would not make them sick. This was an internal motivator for them. Lastly, our resources. By providing adequate resources to employees, for example, thermometers to measure food temperatures, this can help motivate employees to follow safety practices. Okay, so after collecting data in the form of questionnaires and focus groups, we confirmed our research model. Management infrastructure was important for motivating employees. From these results, we chose 2 of the 4 model components, those being communication and recognition and discipline, and we focused our efforts on developing training related to each. This training addressed how managers can use communication to motivate employees to follow food safety practices, and how managers can use recognition, another word might be rewards, and discipline to motivate employees to follow food safety practices. This is the rigorous process we went through to evaluate the training materials that we developed. I will tell you, this took us more than a year to complete this process. First of all, we had review by knowledgeable colleagues. Each module, one module was the communication module, the other module was the recognition and discipline module. So each module was reviewed by an individual with expertise in education and communication, and by at least 4 content experts. Then interviews were conducted with supervisors and managers and dietetics and hospitality management students to evaluate cognitive and motivational qualities. We asked questions such as, are there any concepts in the module that are difficult to understand? Are there words used that you have not heard before and need to have defined? Was the module interesting? Do you think supervisors and managers will learn from the module? Third, we conducted a pilot study with supervisors and managers in 2 commercial and 2 non-commercial food service operations. And then for the final check of the training modules, we verified content and process. 2 experts who were not involved in the study, 2 food service managers, and 2 hospitality and dietetic educators reviewed the modules. Here's the final training product. We called this a supervisor's toolkit and developed both a hard copy of the training in a box that looked like a toolkit, that's what you're seeing on the slide, And then we also developed an online version. The link to the online version is provided on this slide and is available for free. Here is a picture of what it looks like online. The option is either to select the communication or the recognition and discipline module. You can see those showing in the red box. So the supervisor or manager can select one of the modules and then do the other one later on, or they could just do one of the modules. There's a lot of flexibility in the way that we've set this up. Each module is structured in the same way. Each has a pre-assessment test, a checklist for a supervisor to assess their own organization, case studies, audio PowerPoint presentations, examples of standard operating procedures that can be adapted to any food service operation, and a post-assessment, or what we oftentimes call in education, a post-test. The pre-assessment checklist is a self-assessment and asks the manager or supervisor if they agree or disagree with statements relevant to the module topic area. After it is completed, the manager receives a score that indicates how well they are currently doing on motivating their employees using either communication or recognition and discipline. Here are some of the key concepts covered in the communication module. Communication is an important component for any messaging, especially food safety messages. Supervisors and managers should be the primary source of food safety messages. Employees become confused with inconsistent food safety messages. So if one manager tells an employee to wear gloves when handling raw meat and the other one tells them not to, this causes confusion and decreases an employee's motivation to follow safe food handling practices. The second module is on recognition and discipline, and it follows the same order and has the same components as the communication module. It's just focused on a different motivation area. Well, how can the modules be used? We realize that food service managers and supervisors are extremely busy. And so we developed these modules so that they could be used in different ways. The training modules can be used either as a supplement to other training, or they can be used as standalone training. They could become part of professional development for food service managers and supervisors as well. I told you after each project I will present some applications. And so applications for this first project for food service managers and operators. Managers and supervisors are pivotal in helping to motivate employees to follow safe food handling practices. Managers and supervisors can remove barriers so that employees have an easier time keeping food safe. Consistent communication by supervisors and managers is needed. Recognizing and rewarding employees for keeping food safe may help motivate them to follow these safe food handling practices. And resources, that might be having adequate soap, having towels for hand wash, having adequate soap for hand washing, having adequate towels, will help keep food safe. For this applied research project, we had several resources we developed, and also many peer-reviewed journal articles. This slide represents a few of these outputs, including links to the free training materials that were developed. Okay, on to Project 2. Project 2 was titled Developing Food Safety Messages for Food Service Employees. While the first research project was targeted to supervisors and managers in food service operations, this second one targets food service employees. This project was also funded by the United States Department of Agriculture. We had two primary objectives for this research. The first objective was to identify key motivators and barriers contributing to the safe food knowledge behavior gap. Remember, when I indicate knowledge behavior gap, I am referencing the fact that solely because employees know about food safety, that does not mean they will behave in a manner that promotes food safety and mitigates the risk of food poisoning. To collect data and address this first objective, we developed a bilingual nationwide questionnaire and used it to collect data. Our second objective was to develop, implement, and evaluate customized safe food training modules. For this objective, we used a pre-post experimental design to evaluate the training modules by interviewing and observing staff at 9 types of food service operations. And we provided training with the modules via 2 delivery methods, face-to-face and online. Overall, results revealed that training appeared to be effective as evidenced by improvement in the percentage of times hand washing was done properly and an increase in the number of times employees properly used and changed gloves. I'll talk a little bit about those results as we move along here. Okay. So this slide represents one of the potential barriers that we asked about in the questionnaire. The barrier was related to resources and supplies. So the questionnaire asked employees if they had access to adequate supplies that were needed to keep food safe. These supplies on this slide are all related to proper hand washing and glove use. If there are not adequate paper towels available, if there is not hot water to wash hands with, if there's not soap, if there is not a hand washing sink, and if gloves are not made available, it makes it challenging for food service employees to follow safe food handling practices. These are some of the results from the national questionnaire that we distributed. We had 1,399 questionnaires returned, which yielded about a 16.2% response rate. Of those returned, 1,103 were usable. We assessed barriers by age group as shown on the slide. Analysis of top barriers to handle food safety, Analysis of top barriers to handle food safely showed that work pace was perceived consistently as the most important barrier across all age categories. Overall time management issues, different work values, and lack of good habits were the key barriers reported as contributing to that knowledge behavior gap. So with this knowledge of these barriers, we developed food safety training modules for employees. This is a screenshot of the landing page for the training. We developed the training in 2 languages, English and Spanish. The overall focus of this training is to help motivate employees to follow safe food handling practices. So, each module is focused on a different aspect of daily work and how employees can incorporate these food safety practices into their daily workflow. We called our training Do Your Part, where each letter of part, P-A-R-T, stands for a different topic area. The P is for planning, encouraging employees to organize their work. The A is for act, having employees think about how they can work in a smart way. My mentor always called this working smarter, not harder. For example, obtaining all ingredients needed at one time for a recipe rather than an employee going back and forth and back and forth and back and forth from their work area to the storage area to get ingredients to make a recipe. The R is for routine, having employees make food safety a part of their habits when they work, making food safety practices a habit and part of their routine work. The T is for think, having employees think about ways they can improve on their own food safety practices. This slide shows the ACT module. Each training module has 3 components, and you see those kind of down at the bottom here. So there's watch, there's practice, and there's check. Okay, so first there is a watch. This is where the employee watches a short video about the main concept. Then there is a practice where the employee engages in learning and completes some activity related to the concepts presented in the video that they just watched. And then lastly, there's a check. This is where the employee does a post-test assessment. This post-test tests their knowledge, and after they are done, they can print out a certification that they have completed this training. This way, the manager or supervisor has a record that the employee has done the training. You'll see other resources identified on this slide as well. For this second project, I'll talk about application. There are several applications, mainly for food service managers and operators. First, the training modules we developed from this research can be used by supervisors and managers. Training can be done in small increments, so employees do not become overwhelmed with training. For example, an employee could take the training module on planning one day and the training module on ACT another day. We structured those so they're about 15 minutes in length, thinking that employees might have a 15-minute break in their day, and this would be an opportunity during that break time for them to receive some training. Engagement during training is important, even if it's computer training. That is why we developed the practice component for each of the modules. Within the practice some of the activities include a drag and drop. So employees who take the training would drag the appropriate response to the appropriate area. It might be a refrigerator that's set up and they need to drag the appropriate items and place them in the refrigerator where they belong. Reinforcement of training is needed. It's not enough to have employees go through training. Supervisors and managers must consistently reinforce training, and not just reinforce, but consistently train. We know our industry is one of high turnover, certainly pre-COVID, one with high turnover. And so new employees are always starting, employees are leaving. And so having consistent training and reinforcement training is needed. As with the other project, we had several outputs and resources from this second project. The first link that I have on this slide is to the training itself, to the online training. Do your part. In addition, we have had several peer review articles that have been published in journals ranging from food safety journals like the Food Protection Trends Journal to human resource management journals. Again, this was a multi-year project and we had many involved. We've also presented this project at several conferences. So I'm going to give some conclusions to this first part of the webinar. Here are some key conclusions to this first part. First, we recognize that food safety is a global concern and that research in the area of food safety can help advance the field and mitigate the risk of food poisoning outbreaks. Despite having food safety knowledge, individuals, that's consumers, that's food service employees, may not use safe practices. And again, I'll remind you of the example that I gave about my students. They know how to wash their hands properly, but that doesn't mean that they always do it properly. Just because we know how to properly do something does not mean that we always do it and follow through. Research project number 1 was that applied research project where we developed training targeting supervisors and managers with the goal of removing barriers and helping to motivate employees to follow safe food handling practices. Research project 2 that I just went over was another applied research study where we gathered questionnaire responses from more than 1,000 food service employees. We analyzed data and we developed training targeting employees. The focus of that training was on making safe food handling practices part of the work routine, rather than making it an add-on to employees' everyday work. The goal with that training was for employees to learn how to incorporate safe food handling practices into their everyday work routines. Now, we have about 15 minutes for questions related to the first part of this webinar.
Thank you, Prof. Aaron, for such a great sharing about motivating employees to handle food safety and developing food safety messages for food service employees. We see that there are so many questions posted on the social media. Thank you so much for your active participation. Our team has selected some of the questions. Okay, so the first question is, may I know how to determine if the onion is contaminated by Salmonella? Okay, Prof. Aaron?
That's a great question. So the question was, how would I know if that red onion was contaminated? And I think the only way that we would know if that red onion was contaminated was to run it through the laboratory testing. We would not know by looking at an onion if it was contaminated or not. This question reminds me about a listeria outbreak that we had here in Iowa, and listeria had contaminated cantaloupe melons. And consumers wanted to know how they could wash away the listeria. It's really can't be done. And so we can't know just by looking at a food if it's contaminated, and many times we can't, for something like listeria, we can't wash it away. So excellent question.
Okay, thank you, Prof. Okay, moving on to the second questions from the audience. What is the food safety approach to strengthening the resilience in developing countries, especially during this pandemic of COVID-19 pandemic?
Okay, so if I'm understanding correctly, the question was about resilience related to food safety. Is that correct?
Yes.
Could you please restate the question?
What is the food safety approach to strengthening the resilience in developing countries, especially during this pandemic of COVID-19?
Yeah, good, another great question. We've got a great audience on with us today.
Yes.
It's Stump the Speaker Day. Okay, so I think we have, there are lots of not so good things that have come out of the pandemic. But I think one of the things that we can capitalize on in the food safety arena and increase our resilience related to food safety is in this notion and linkage between hand hygiene and decrease risk of acquiring a virus. Okay, so we've heard a lot about that in relationship to coronavirus. So I think we have opportunity to continue the same messaging related to hand washing and prevention of virus, prevention of contamination as it's related to food. And particularly in developing countries, I think this is very applicable.
Okay, thank you, Prof. Aaron. Okay, so we still have time for the third question. What is the major impact of COVID-19 on food safety in your living area or state?
Yeah, that's a good question. We had, there's a couple things that are happening. One is that because consumers are much more focused on coronavirus, we are not seeing reports of food poisoning at the level that we did before coronavirus. So that's one thing. Second of all, we're seeing several myths about transmission of coronavirus, particularly on food containers. And so there was a study done by one of my colleagues just recently that looked at how many consumers are purchasing food from restaurants, and they are, when they get the food, they are then sanitizing the packaging that they receive that food in. And this is not recommended, but again, it's a myth or a perception. So there are some myths and perceptions that are being perpetuated in certain audiences related to coronavirus and food safety. So that's one of the challenges I think we had early on in the pandemic, was to try to dispel some of these myths. So I guess in summation, it's the lack of reporting, and we don't know if that's because in fact there is less food poisoning, and then these myths and misperceptions that have emerged linking coronavirus and potential risk related to food safety. Thank you for the question.
Okay, good. Thank you, Dr. Aaron. Next question. So we have active participation from the audience. Good.
We love that.
Yeah. All right. Next question. Reinforcing of training sometimes can't be implemented because of the time barrier. How can we make sure that employers emphasize this?
Okay, so the question is on, there's challenges reinforcing training, and there's time constraints, there's employee turnover, and so what can be done in this regards? And so actually, one of the projects that I'll talk about after break here a little bit is on some messaging strategies that might be used in the operation. So even if there's not opportunity to have employees sit down and do a computer training, there are some messaging or signage that can be used in the operation to help remind employees. I think the other thing, and I would be remiss if I didn't mention it, supervisors and managers serve as role models to employees. So another fairly simple approach is to make sure that supervisors and managers in operations are role modeling those food safety practices. And so that means that managers and supervisors are, in the United States, we need to wear hair coverings in operations. So managers and supervisors also wear hair coverings. Managers and supervisors also practice appropriate and correct hand washing procedures. So those are just a couple strategies I'll mention at present. Thank you.
Okay, thank you, Dr. Aaron. I think we can have the last question. Okay, last question for this part one slot. So what are the challenges in managing food safety when it comes to street food?
Excellent question. There are more challenges, right? And because we call them mobile units in the United States, but I've been to Malaysia and I love street food. So we don't have the same facilities oftentimes for our mobile units. So there might not be running water or a hand washing sink, and washing hands becomes challenging, and we might not have all the equipment that we need, or we might have limited equipment to keep hot food hot and cold food cold. These are real challenges and real barriers for keeping food safe, street food safe. what we often find in the United States is that for our mobile units, oftentimes vendors will pick a niche food item. They don't try to serve all kinds of food items. So they might just be serving soups. And so they don't need as much equipment. They don't need a whole bunch of hot equipment. They need the equipment to keep the soup hot, but they don't need maybe a whole bunch of refrigeration or the like. So strategizing their menu in a way that allows them to keep food safe with the equipment that they have.
Thank you. Thank you, Dr. Aaron. Thank you for the questions, and thank you again, Professor Aaron, for your responses. So now we will take a short break and we will come back after 5 minutes.
Welcome back to the international webinar on food safety research, application to consumers and food service operators. We will continue the second part of the webinar. To all attendees, if you have any questions related to today's webinar, feel free to post on the chat box. Now, I would like to welcome Prof. Dr. Susan Waldorf-Arendt to deliver her talk. Please welcome.
Thank you. I'm going to go ahead and share my screen. Are you able to see my slide? Well, welcome back. Welcome back. I hope you were able to step away from your screen and get a little stretch break in. I know I did. For the second part of this webinar, I'm going to present 3 additional research studies. The first one is about why consumers and healthcare professionals do not report food poisoning to health officials. In other words, if consumers think they are sick because of something they ate, why don't they either contact their doctor or health officials? And likewise, if a consumer goes to the doctor and is sick because of eating a potentially contaminated food, why doesn't the doctor report that to the health officials? For this project, we had 2 primary purposes. The first was to identify barriers to the underreporting of food poisoning by consumers and healthcare professionals. The second was to propose solutions to overcome these identified barriers. Now, before we go any further, I believe it is important to understand how we investigate a potential food poisoning outbreak in the United States. The very first step in the process is either the individual consumer reports their illness to the health officials, or the individual goes to their doctor and the doctor reports to the health officials. Nothing can be done until an initial report happens. After a report is made, then local officials will conduct an epidemiological investigation. They will look for others with similar illnesses in the population. They will run stool and blood tests on those that are ill and test the suspected food if it's still available. After the local officials have done their investigation, the national officials get involved. This is where the information is shared with the Centers for Disease Control, who are in charge of protecting the health of people in the United States. For this research, we used focus groups for data collection. Because our research was for the state of Iowa, we conducted focus groups with consumers in Iowa and with healthcare professionals in Iowa. In the first phase of the study, we conducted 3 face-to-face focus groups with consumers in 3 Iowa cities. And then in the second phase, we conducted focus groups with healthcare professionals in 4 different cities. These healthcare professionals were individuals like nurses and doctors. For anyone who has used focus groups for data collection, you know the challenges of recruitment and making sure that participants show up for the focus groups. We recruited participants many ways, including posting flyers at work sites, public areas like libraries, and using our networks in each part of Iowa. Prior to each focus group, participants filled out a short questionnaire about their attitudes toward food safety, and they also provided demographic information. We had snacks for participants, and to honor honor anonymity and confidentiality, we had participants use a name other than their own during the focus groups. In other words, they used a pseudonym. We used an experienced moderator to lead the focus groups and also had an assistant moderator who took notes. All of the focus groups were audio recorded and transcribed verbatim. Here are some of the questions we asked consumers during the focus groups. We asked them things like, have you ever suffered from food poisoning? How did you know your illness was from food and not from something else, like the stomach flu? What did they do when they got sick? Did they report it? And if they did report it, who did they report it to? We wanted to know what could make it easier for them to report when they thought they were ill because of a food. How hard did they think it was to collect a usable stool sample? Because this is one way to diagnose food poisoning. And because, and then we also had questions for the healthcare professionals. This slide represents some of the questions we asked them. We wanted to know what their level of concern was for their patients or clients in regards to the safety of food. We wanted to know where they believed or what they believed about their clients or patients and what they thought the greatest risk for food poisoning was. We wanted to know the barriers to diagnosing food poisoning, and we wanted to know about their experiences with patients who had food poisoning. We wanted to know why they would suspect if it was food poisoning and not something else. This table represents the demographics of those who participated in the consumer focus groups. We had a variety of age ranges and income levels. The majority were female. From the short questionnaire that consumers filled out before starting the focus groups, we found that 80% did not have a food allergy. Now, we wanted to make sure that individuals were not confusing a food allergic reaction with food poisoning, so that's why we asked that question. About 34% thought they had had food poisoning fairly recently in the last 3 months prior to the focus group, while about 90% indicated that at some time in their life, they had gotten sick from something they had eaten. During the focus groups, here are some of the responses we got to the question, if you thought you had food poisoning, who would you report it to? Some said the Poison Center. Now, this is a federal organization in the United States that handles chemical poisonings. So if I thought my child had accidentally drank some household chemical cleaning products, this is where I would call. I would call the food poison, or not, excuse me, I'd call the Poison Center. Okay. Now, many said they would call a nurse or another healthcare professional. Some said that they would call the Food and Drug Administration. Again, this is another federal agency in the United States. Many of the respondents that were involved in the focus groups said that they would call the restaurant where they thought they had gotten the food poisoning from. And we found that very interesting. From the focus groups, data analysis indicated that consumers knew that they had food poisoning due to how severe their symptoms were and how long the symptoms lasted. Generally, they said the symptoms were fairly short-lived, usually less than 2 days. And we heard very vivid and detailed stories about their symptoms. I will not share any of them with you on this webinar. Most indicated that they did not report their suspected food poisoning because either they were unsure of who to contact, they were just too ill to even think about calling someone, They were uncertain of the cause or source of the illness. They relayed to us that they thought they needed to know exactly what food made them ill, that they believed they shouldn't contact or report anything unless they were absolutely sure what the food was that made them ill. And many said they didn't think it would really matter if they reported it or not, so they didn't make any effort to report. We asked consumers what would be the best way to get information about how to report food poisoning. Again, I'll remind you at the beginning of this webinar, I talked about those estimated numbers of cases of food poisoning. This is why they're estimated, because individuals don't report. So we asked them what would be the best way to get information about how to report food poisoning. Some said, oh, it would be good if there was a memorable telephone number. In the United States, we have a great problem with gambling, and so we have a phone number for individuals who have concerns because they are gambling too much. It's called 1-800-BETS-OFF that they dial if they need help. So the focus group participants thought it would be helpful if there was a memorable phone number for them to call. Some of them thought it would be helpful if there was information posted on the internet. Others thought that there should be postings at restaurants, something like, if you think you got sick from our food, you could call this number. I don't know how the restaurants would receive that. We decided not to move forward with that suggestion. Then we asked them what would make it easier to report an illness. They said education. They wanted to make sure someone cared, and they wanted to know that someone would be held accountable. So if they reported that they were ill, then would the restaurant or would someone be held accountable for their sickness? Now, transitioning to the healthcare providers focus group. These are the demographics of those that were in the focus group for the healthcare providers. They were all female and all Caucasian. It was equally split amongst 3 age categories. The majority worked in a medical clinic. Most were full-time employees, and most listed their title as other. Things like office nurse and medical assistant were some of the titles, their professional titles. On that questionnaire that they took before the focus group started, they indicated their beliefs and attitudes about food poisoning and about food safety. The majority believed that food service operations had the greatest risk for food poisoning incidents. So what they were saying is that restaurants, they believed most food poisoning happened from restaurants versus individuals who cooked at home cooking. The majority had never cared for a patient with food poisoning, and the frequency of which they saw patients with food-related complaints was fairly low. Again, from that short questionnaire, healthcare providers indicated there were barriers to diagnosing food poisoning. These were some of the barriers that they identified. They said the time between food ingesting and treatment. Oftentimes, they said a patient would wait so long between when they ate the food and when they came in to see the doctor or mention it to the healthcare professional that the time period had been almost too long. Lack of patient knowledge and cost was certainly a barrier. It costs to have laboratory tests done to test patients to determine if they do have food poisoning. Some of the healthcare providers thought that the food absolutely had to be available for them to diagnose food poisoning. And so some of them said, well, the suspected food wasn't available. This was very interesting to us that the healthcare providers had this misconception that that was the only way to diagnose food poisoning was actually to test the food. As we know, patients can be tested. Usually the most simple test is a stool sample. And then overall lack of healthcare provider knowledge. Here are some of the illustrative quotes, just a couple of them that we heard during the focus group. The first one, it's just better to treat the symptoms and say follow up if you don't improve in the next couple of days. We heard this often. Many healthcare providers would treat the symptoms, oftentimes with an antibiotic, rather than do the testing to see if there was actually, if the patient actually had food poisoning. Healthcare providers would often say, well, go home and give a stool sample and bring it back into the laboratory. And what would happen in those cases oftentimes is the patient would not bring in the stool sample and would never be tested. Here are some of the overall themes that we found from those focus group transcripts or by analyzing those transcripts from the focus groups with the healthcare professionals. Experiences working with suspected food poisoning focused on treating the symptoms. They knew to suspect a foodborne illness or food poisoning because of the severity and duration of symptoms, because of their own personal experiences with food poisoning, or because multiple people had presented with the same symptoms and had eaten the same food at the same place. Action steps if food poisoning was suspected. Some of them said they would make a phone call to the health officials. Some said that they would ask further questions of the patient. Others said that they would do diagnostic testing, both stool or blood tests. Additionally, some of the other findings or themes from the healthcare professional focus groups, issues related to diagnosing food poisoning included costs, required tests, patient's knowledge. The patient couldn't remember what they ate, when they ate it, when they got sick, or if they got sick from something else. Healthcare provider knowledge. We found that many in the focus group did not know about food poisoning and how to diagnose it. As I mentioned, the suspected food was not available, and that time lapse was so great between when the patient came down with symptoms and when they actually went to see their healthcare provider or contacted their healthcare provider. There's lots of barriers with getting stool samples, and again, that's how they generally diagnose food poisoning. And there's issues with cost, lack of knowledge, and some overall reluctance of patients to do a stool sample test. There's challenges in collecting the stool sample, and many healthcare providers indicated that they would rather just treat the symptoms rather than doing the test. In addition, sometimes the symptoms were so mild that there was no reason to do, the healthcare providers felt there was no reason to do the stool sample test. Here's some of the conclusions based on this research and potential implications. Barriers for reporting food poisoning to local officials exist for both consumers and healthcare professionals. The barriers that were identified could be overcome through targeted education, both education to consumers as well as education to healthcare professionals. And I've identified on the slide maybe some of those topic areas for education. Identified barriers could also be overcome by improving access and information regarding food poisoning reporting. And again, they mentioned that memorable phone number, having information available to consumers potentially at restaurant, and then also centralizing our statewide reporting system. Well, as I said, I am presenting to you many applied research studies here, and this was what came out of all of this research, or this was the solution that was put forward after we presented our data to the health officials. They developed, in conjunction with our help, Ralph. And Ralph is an emoji, and he was developed as a result of the findings of this study. In addition, they developed this memorable phone number, 844 I was sick. And on the next slide, I am going to play the short TV ad that is periodically run on our television stations here in Iowa. So I'm going to advance the slide, and we will hope that you can hear Ralph in action.
Hey, feeling queasy? Uh-huh. If you think you have food poisoning from food or drinks made outside your home, you should report it. Huh? Call toll-free 844 Iowa Sick or your local health department to stop an outbreak of food poisoning. Feeling queasy? Call. It's easy. 844-IOWA-SIC.
Okay, that was Ralph in action. They run those ads at different times of the year, and they have found significant increase in numbers of phone calls when they run those PR pieces on the television. So that was some real exciting research that we got to be a part of, and it's neat to see the outcomes of that work and have impact on reporting of food poisoning in Iowa. I'm going to give some application related to the study. For this project, there are applications both to consumers as well as health workers. From the consumer perspective, most consumers in the United States do not report to local health officials or their doctors if they believe they have food poisoning. It is important for consumers to report because this allows officials to monitor, to track, and to come up with potential solutions. Public service announcements and campaigns, like Ralph, can help increase reporting of suspected food poisoning cases. Now, for health workers, it's important that healthcare professionals know the signs of food poisoning so they can help patients identify if they have potentially gotten food poisoning. It's important for healthcare workers to encourage patients to see their doctor and get tested if they think they have food poisoning, and also educate patients on how to mitigate risks of food poisoning. Well, the primary resources and outputs from this project, certainly the big one was Ralph and the development of the public service announcement and memorable phone number. We also produced a peer-reviewed publication in the International Journal of Environmental Research and Public Health. So moving on to the fourth research project that I'm going to share with you. This one focused on handling leafy greens and then handling leafy greens in service to older Americans. We had 4 objectives, and this was an intervention study, and it posed lots of challenges. Well, our first objective was to identify current food service employee handling practices of leafy greens, things like lettuce, kale, spinach. We conducted microbial assessment, considering procurement form, source, and also looking at contact surfaces. Then we took our findings, the applied research part of this, about those practices and the microbial assessment data, and developed effective food safety messages. Lastly, we implemented and evaluated the safe food handling messages. Okay, so the intervention was the messages that we used in some of these facilities. Okay, so a bit of background. Our population in America is aging, and we have many adults who are 65 years and older. Some of these adults are free living, meaning they are still in their own homes, but many live in elderly care facilities. Older adults are considered a vulnerable or at-risk population for contracting a foodborne illness or for contracting food poisoning. Additionally, we know that several food poisoning outbreaks have been linked to leafy greens. At the time we did this research in the United States, there had been 25 multi-state outbreaks linked to leafy green items, including cabbage, prepackaged lettuce, spinach, and also leaf lettuce that was not prepackaged. Because leafy greens are generally eaten raw, we have standards in the United States that indicate that raw, or sometimes what we call ready-to-eat foods, cannot be handled with bare hands. Either gloves need to be used or a utensil needs to be used when handling those ready-to-eat foods like leafy greens. This slide illustrates that microorganisms can even be found on glove boxes holding gloves in food service operations. Okay. Here are some of the pictures that we took while we were in the operations. We took samples from product upon receipt, like that in the box here, and also at the time of service. And here's a pan of leafy greens awaiting service, and there's another pan underneath it that holds the ice that is used to keep those leafy greens cool during the service period. Now, we also recognize that microorganisms can be transferred from hands or packaging to ready-to-eat product. Here's an example and trying to illustrate that there are those microorganisms that were found on the bottom of the lettuce box, and also then from the fingers that touched that lettuce box, so that cross-contamination in this case. This slide gives a brief overview of the methods. So for this project, we had a pre-intervention phase, a short-term post-intervention phase, and then a longer-term intervention phase. We went to 8 sites. These included sites like elderly care facilities and hospitals, and we conducted an operations observation, an employee observation and interview, and we did micro sampling of contact surfaces and also leafy green product at different times. That's where we looked at receiving, and then before preparation, and then at the time of service. Then we developed our intervention, which was the development of 8 food safety messaging posters. And then after development, we implemented those in those 8 sites. And then after implementation of the posters that had these food safety messages on them, we collected data again using the same approach as we did at pre-intervention. We did short-term and long-term follow-up after the intervention. We know that short-term intervention usually works, but in the long term, food safety messages may be ignored as employees get used to seeing the posters every day. That's why we did that short period about a 1 month after intervention, and then a longer period, so about 3 months after intervention. This just shows a photo of the sampling of the product itself. So at this facility, they were having a mixed lettuce salad that day. We collected them in these bags, and we collected about half a bag's worth of product. Just want to make sure. Yep. Okay. We needed to develop a protocol just in case we had a positive for whatever bacteria we might find. So we developed a protocol and potential corrective action if we did happen to find something. And that's all this slide is illustrating. Based on our findings, we developed, as I indicated, 8 posters. So we analyzed the data that we found in that pre-intervention phase when we did observation. We analyzed the operation, we interviewed employees, and then we developed these 8 posters. One of the things we found when we did that pre-intervention data collection was that oftentimes employees would wash pre-bagged greens that had already been pre-washed and they were ready to eat. This is not recommended as it introduces another opportunity for contamination. Therefore, one of the posters we developed specifically was about not washing pre-bagged leafy greens that had already been washed. This slide gives examples of some of the posters. We developed posters in 3 languages. We developed them in Spanish, in Mandarin Chinese, and in English. The posters were developed with minimal text, so there wasn't a lot of writing on them. We tried to use visuals. And so you can see the one in the middle, just by looking at it, even if you can't read it, you know that you see that there are circles with the red mark through them, meaning don't do these things. And so even if we can't read it, we can get the message that there are certain things that we should not do. We've got sneezing and we've got touching our forehead, all of those types of things that we don't want to see in a food service operation. The posters were implemented, and here are some pictures of where the posters hung in the food service operations. We allowed the managers to decide where they were going to hang the posters. Some hung them in the salad preparation area. Some hung them on refrigerator doors. That's what that blue poster is hanging on, a refrigerator door. And some hung them on areas that were close to the dining area. And I love this poster. On the right, the message is, "My health is in your hands." And so again, this emphasis on hand washing, in that by washing hands, we can keep our older Americans healthy. This next slide is a graph that attempts to show you what we found. And when you look at this, you will see that compliance was all over the place. So we have pre-intervention, intervention, and post-intervention. Pre-intervention, short-term intervention, and long-term intervention. Okay. And you see at some of the sites that compliance with food handling behavior increased after intervention. In some sites, it decreased. And in some sites, it went down and then went up long term. You can see that there is no consistency Some operations showed improvements, short term, others did not. As you might expect, several variables impacted results, and we could not control for these. That's the beauty of doing research in actual operations. For example, on days of observation, there was a different menu generally than on the other days that we had done observation. There were different employees that were working. And at one site, there was even management turnover. So when we started the project, there was one manager. And then by the time we were ready to go back for the long-term intervention part of it, there was a new manager. And so the culture of that food service operation had changed because there was new leadership. Well, we can certainly present the microbial results. The good news was that we found no Listeria monocytogenes, no E. coli 0157, or Staphylococcus aureus in any of the samples. That's good news. We looked at differences between leafy greens at different stages in the flow of food, again from receiving through service, and found no differences. There were no differences between the sites and also between the two states. We had sites in two different states. There was no significant difference between site type, meaning between long-term care facility and hospital or senior living facility and hospital, except for generic E. coli, which is an indicator of fecal contamination. And I am told by our microbiologists that it's not uncommon to find. Okay, so applications. For consumers, based on the project, here are some application points for consumers. We always tell consumers to handle leafy greens and all ready-to-eat foods with care. Wash leafy greens to remove soil if they have not already been pre-washed and bagged. And of course, hand hygiene is important when handling leafy greens, and leafy greens should be kept refrigerated. Now, application to food service managers. Again, multiple interventions are needed over time as employees started to ignore the posters over time. And at one facility, they did rotate the posters. So they put up 3 for a couple weeks, and then they take those 3 down, and then they put up 3 new ones because we had 8 in the series. And actually, at that facility, that was one of those where they saw increased compliance at both intervention, at both short-term and long-term. The visuals of the agar plate. So you saw several of the posters had those agar plates on them. Employees liked those. They felt that the messages were scientific when they saw those agar plates on them, and it made them feel special. That they had control over something that was so scientific. And we found that very interesting. Certainly for managers, they can use these posters. They're available for free through our extension store, and the link is there on the slide. We have many outputs, again, from all of our research projects. We've got a couple peer-reviewed articles that are listed at the top of this slide, and we also have the posters that are available in those 3 languages. Now, to our last and most recent study on food safety. And one of our moderators was involved in this study as well. So we're going to transition a little bit. All those other studies were really about food safety and operations that were commercial food service operations or non-commercial food service operations, we're going to shift a little bit and talk about retail food service. And we're talking about retail delicatessens in Iowa. This is the research team. We had a phenomenal research team. And we had partners from the state agencies, the Iowa Department of Inspections and Appeals. We also worked with experts at our state hygienic lab, and some of you may recognize another name on that list. This work was partially funded by the United States Food and Drug Administration. I wanted to show you, this is a picture of what a retail delicatessen might look like, or in short, we call them delis. It's generally a large counter, and there's oftentimes pre-cut or whole processed pieces of meat and cheeses, and oftentimes these meats and cheeses are used in sandwich making. These meats and cheeses are generally considered ready to eat, so there is no further kill step in prior to eating. So these generally are not heated or cooked prior to eating. We had two primary purposes for the study. First of all, we wanted to determine the prevalence of Listeria monocytogenes in selected Iowa retail delis. And then we wanted to assess operational environmental aspects that mitigate contamination of ready-to-eat products with Listeria monocytogenes. And we were using 8 recommendations that the United States Department of Agriculture have released in regarding monocytogenes reduction in retail delis specifically, and I'll show you what those are as we move along here. A very brief review of literature. Sliced deli meats are a major source of Listeria monocytogenes outbreaks. The majority of these listeriosis cases are associated with eating contaminated, ready-to-eat food, which has been temperature abused or cross-contaminated. So keeping foods at too warm of a temperature or contaminating them with dirty hands or from raw foods. Listeria monocytogenes may enter retail delis through various routes, including employees, equipment, raw product, and cross-contamination. Therefore, it's so important for employees to follow safe food handling practices, as well as clean and sanitize facilities and equipment. The United States Department of Agriculture, as I indicated before, introduced Listeria monocytogenes guidance for safe handling and maintenance of facilities, resulting in 8 best practices for retail delis. Here's an overview of our methods. We had 2 data collection techniques. We did that environmental assessment, and we had an instrument that we used to determine environmental factors and practices. And then there 5 to 9 microbial samples were collected at each of the retail delis. We did 2 pilot data collection periods and then a final data collection period. All data were collected during routine health inspections because all retail delis are inspected on a routine basis. The health inspectors conducted the environmental assessment and took the microbial samples in addition to performing their usual inspection at the deli. Our experts at the Iowa Hygienic Lab worked with us on the pilot testing process. During the first pilot, we had many false positives, and we were using a newer product, and so the lab ended up using the traditional method for testing. This delayed our project quite a bit because we needed to do a couple pilot studies. Here's how we selected the delis to sample in Iowa. We had a total of 57 delis in our sample. Because many retail delis are located within a larger grocery store, we differentiated between those small and large deli operations. We selected more small delis to be in the study than large delis because past inspections indicated that smaller delis had more food safety violations than larger delis. So we had 43 small delis and 14 large delis in our study. This is part of the environmental assessment instrument used for data collection. Questions related to cross-contamination are asked. For example, are there separate utensils for raw and ready-to-eat foods? And here you can also see questions related to refrigeration. I have to show this because one of the members on our research team wrote up very detailed instructions for the data recording process, and we called these the marking instructions. So this was so that those that were collecting the data knew exactly how to fill out this assessment form. Each question had a detailed description on how to fill out that data collection instrument. For the microbial sampling, in total, there were 3 trained inspectors that did the sampling. They sampled several surfaces, including cutting boards, meat slicers, and the deli case. All samples were shipped same day for analysis. This is what that sample collection form looked like. You can see that we identified samples by zone, which indicates proximity to the product. So zone 1 indicates close proximity to the product, that being the deli meats and or cheeses. 2 would be a little bit further away from the product. After samples were sent to the lab, this is the analysis process that was followed. Because I am not a microbiologist, nor do I claim to know a lot about microbiology, I will not elaborate on this further. On this slide, we compare our findings on the retail delis in Iowa to a national retail deli sample. We use those 8 recommended best practices, and you can see those are identified on the left-hand side. The only area that the Iowa sample performed better was the recommendation of covering, wrapping, and protecting ready-to-eat foods. Otherwise, you can see that the Iowa delis performed worse, did not adhere to the 8 recommendations, as well as the national sample did. We also did that comparison based on size of the deli relative to the overall 8 recommendations and compliance. In all but one of the 8 recommendations, the smaller delis had lower compliance. This was not surprising, as we had specifically oversampled those smaller delis, given that often their health inspection scores were lower than those of larger delis. Here we have the microbial results. We had 3 samples that were positive for Listeria monocytogenes. Okay, remember that we took multiple samples at each retail deli. This slide also shows the sampling location. So the slicer was the most frequently sampled, followed by the deli case. Of the 3 positive samples, 2 were from small delis and 1 was from a larger deli. This slide shows what was done after finding a positive result. Okay, so you see 4 retailers identified there. Remember, I said 3 positive for Listeria monocytogenes. We had another site that was positive for Listeria welshmeri. For the 3 operations where Listeria monocytogenes was found, it was found on deli case, slicer, and slicer table, respectively. Follow-up and corrective action was taken, as you can see on the slide. I think that's, for sake of time, I think that's all I'm going to talk about related to the microbial sampling and findings. Certainly, the published article on this work goes into that more in detail. For this project on Iowa retail delis, here are some of the general conclusions. Microbial sampling was limited to zones 1 and 2. So we did not sample other zones. So zones that were further away from product, we did not sample. We sampled areas that came in direct contact or were adjacent to the product, meat, cheeses. Slicer table, interior of deli case. Given the ability of Listeria to exist in biofilms, it is recommended that different sanitizers be rotated and that proper concentration of sanitizers be used. And as compared to the national federal data, Iowa delis in the study that we did had lower compliance with 7 of the 8 recommendations. We certainly recognize that more investigation is needed to determine the main causes of these differences in food handling practices for retail delis based on size and location. Here are some related applications for consumers. The U.S. Centers for Disease and Control recommend that pregnant women do not eat deli meats because of this risk of Listeria. Or if they do, they recommend heating meat to an internal temperature of 74 degrees Celsius. When handling deli meats and cheeses, consumers should use safe handling practices like proper hand washing and avoiding cross-contamination. And high-risk populations like those older adults, pregnant women, should avoid soft cheeses like brie, blue vein cheeses, or queso fresco. Overall, the recommendation is to avoid raw and pasteurized milk. So for this final research project, here are some potential applications for food service managers and operators. When slicing meat or cheese with a mechanical slicer, which these delis generally did, clean and sanitize the slicer between uses. This would also apply if using a knife for slicing. Clean and sanitize work surfaces and cutting boards to prevent cross-contamination, and certainly follow safe handling practices and proper hand washing procedures. Thus far, we have 1 peer-reviewed article from this work, and it was just recently published in the Journal of Food Protection Trends. This was the last research. I can't even talk anymore. This was the last research project I will be presenting, so I will wrap up the webinar with some concluding slides. First, based on the information and research I have presented in this webinar, here are some general conclusions about consumers and food safety. Consumers can mitigate their risk of getting food poisoning by following safe food handling practices at home and when eating out. Selecting food service establishments that have safety protocols in place. Consumers in the United States do not report to their healthcare providers that they think they have food poisoning for a variety of reasons. And before selecting a restaurant to eat at, consumers may wish to observe employee behavior related to food safety. I have a colleague at work who will go out to eat at restaurants, but she will carefully watch restaurant employees behave and handle food. She will not return to a restaurant if she sees an employee who does not use care when handling food. If my colleague sees an employee, oops, that was my time. If my colleague sees an employee sneeze on the food or not wash their hands after using the restroom, she will not go back to that restaurant. Based on the information and research I have presented in this webinar, there are also some general conclusions about food service operators, employees, and food safety. Managers and supervisors can help to motivate employees to follow safe handling of food, like washing hands, maintaining food at appropriate temperatures, and not cross-contaminating. Managers and supervisors can provide resources to employees to help them follow safe handling practices. Resources like thermometers to take food temperatures and soap and towels for hand washing. Food service employees are the last line of defense. By this, I mean that food service employees can increase the risk of food poisoning or mitigate the risk of food poisoning. As an example, employees can contaminate food before it is served, leading to food poisoning, or employees can cook and hold food to proper temperatures to mitigate the risk of food poisoning. That concludes my presentation of the last 3 projects. We now have some time for questions, I believe.
All right. Thank you, Prof. Aaron, for sharing your research projects on food safety. It's very valuable information. Your presentation held audience attention for hours. Now, Prof. Aaron will answer some questions from audiences that were sent to us during the presentation. Okay, the first question is, good day, Prof. How the Industrial Revolution and the use of technology can increase the quality and the safety of food services worldwide? You want me to repeat again the question?
One more time, please.
Okay. How the Industrial Revolution and the use of technology can increase the quality and the safety of food services worldwide?
Excellent question. We could spend many more hours talking about this, but we won't. I'm going to address this technological advances in processing of food and procuring food have helped in advancing food safety all over. I was recently talking with one of our research members, and we were talking about even some of the technology that has advanced in regards to cleaning and sanitizing, whether that be in a processing plant or whether that be in a retail deli operation or whether that be in some of our food service kitchens. That is just a very, very simple example, but I think we have lots and lots of technological advancements that are aiding us in food safety. We have lots of new tests that are in place at the processing plants that can be used for detection. And again, that's just another example, but there's certainly lots and lots of examples that we could talk about technology advancing the safety of our food supply.
Thank you. We have another question we receive a lot of questions actually. So for the second questions, hello Prof, you just mentioned sometimes the patient doesn't bring any stool samples for laboratory tests. Is there any alternative ways to solve this problem?
Thank you for the question. As a former healthcare provider and registered dietitian who worked in hospitals, I'm always intrigued by various laboratory tests. We spent a lot of time talking about acquiring stool samples when we were involved in this research project. And the outcome of that was that our health department, our Iowa Department of Public Health, developed a video on how to collect a stool sample at home, because that's what was happening, is that patients were going in to see their healthcare provider, and because they couldn't produce a stool sample at that point in time, the healthcare provider sent them home and said, go do it at home. And so a video was prepared and made available for patients on how to collect a stool sample at home with items, equipment that individuals may have at home that they could use for that collection process.
I think they like Rolf. Rolf, because next question is related to the previous questions. I have a question. What is the best strategy? Oh, sorry. Okay. Does individual who had food poisoning that went to pharmacy to buy medicine instead of meeting a physician or doctor is count as reported case?
That's a really good point. So if a patient goes to a physician or doesn't go to a physician, the reporting piece to all of that is that the healthcare provider needs to notify the local health authority, or the patient needs to notify the health authority. And generally that is not done. What happens is that the healthcare provider writes a prescription, and that patient goes and gets the prescription or to take care of their symptoms. And the healthcare provider never reports it to the local healthcare health agency, health officials. And so it is not reported. And this is a huge problem, because we don't have any idea at the actual number of outbreaks that we have. And it makes it very complicated to address food poisoning if we don't know what cases we have and where they're coming from and the like. So no, that would not be a case. That would be considered not reported.
Okay. The next question also related to reported case, food poisoning case. I have a question. What is the best strategies that should be implemented to encourage the consumers the importance of reporting the food poisoning cases?
Yeah, that's a great question. So how do we motivate consumers to report? And what we heard from consumers is, well, if we report, we want somebody to be held accountable. We want the restaurant to get in trouble because they made us sick. Well, that's not the way we usually work, right? So I think if we could convey in the United States the message of what is the benefit of reporting. So if you do report, these are the potential benefits. And we in the United States are very much about ourselves. So it has to be, what is the benefit to me as an individual? How would I benefit if I report it? And so we would need to come up with some motivator to somehow get across to consumers that it would be of benefit to them individually. Yes, it's nice that we benefit all of society, but we find that individuals want to have their own benefit as well. So we need to come up with some way to convey that to consumers. I don't know what that is.
Okay, we need to find that with the research. Okay, we have another question. As the US is a diverse, what are the differences, if any, in the level of awareness between different ethnicity on food safety?
Yeah, great question. So the question is about a level of awareness related to food safety, potentially based on different ethnicities. And, you know, if we think about, if I asked you, where did you learn about food safety? You know, and we asked employees, how did you learn about food safety? They learned about food safety in the home and from their families. I learned about food safety from my grandma. She would take her big turkey at Thanksgiving and set it on the counter to thaw it out. That's how I learned about food safety. And so I think, irrespective of who it is, we learn about food safety oftentimes in the home. And so based on different ethnicities and different beliefs about food and holding the food, we do see differences related to food safety practices and food safety beliefs.
I think that's the last question for you. Actually, we have more questions. Maybe we can ask or can email you the questions later.
Yes, please don't hesitate to email. If anybody has any questions, I'd be happy to answer them.
All right. Thank you, Prof. Arendt. We were glad you reserved a few minutes to answer questions from the audiences. Now, I would like to welcome Prof. Dr. Zamri Sekawi, Dean, Faculty of Medicine and Health Sciences, University Putra Malaysia, to deliver his closing speech.
Thank you, Madam Chairperson. Can you all hear me?
Yes.
Great. Professor Dr. Susan Wolof Aaron from the Iowa State University. I'm not sure whether I pronounced your name correctly. Sorry about that. The Rector of UITM Pulau Pinang, Professor Technologist Dr. Salmia Kasolang, and Deputy Rector UITM Cawangan Pulau Pinang, Professor Insinyur Dr. Ahmad Rashidi Razali, the Chairpersons Dr. Nur Hidayah Cik Ahmad from the Faculty of Hotel and Tourism Management UITM Penang, and Dr. Shafika Rahmat from the Department of Dietetics, Faculty of Medicine and Sciences, UPM, University Putra Malaysia, students and lecturers of the universities, ladies and gentlemen. So, Assalamualaikum warahmatullahi, and a very good afternoon, and maybe good evening to Professor Aaron. It's almost close to midnight there in Iowa, I suppose. So pity you, the students were, I think, torturing you to give a lecture at midnight. Right. First of all, I'd like to say congratulations to the organizing committee, who has worked tirelessly to ensure the success of the international webinar on food safety research applications to consumers and food service operators. And I'm very honored with the presence of Professor Aaron from Iowa State University. So thank you for spending time with us and sharing your expertise and current research finding with us today. I came about half an hour ago, so I have listened to your talk and I've benefit. And consumers in Malaysia is the same. We do not report to the health care authorities if they have got food poisoning. And so we have to get that, find out what is the big question is how to motivate them to report. So that would be like very local context, maybe different from consumers in the US. Right, and food safety, as you know, is very relevant to us today and of utmost importance for food service operations. And it helps to protect the health of consumers from food poisoning. I'm a clinical microbiologist, so I can relate to the pathogens that you have mentioned just now. And I hope that the objective of this webinar is fully achieved. All the topics were well discussed, and I'm sure it's very appropriate to the participants, especially to the students. I hope that the participants of this seminar, especially the students, now have a better understanding on food safety and able to produce safer food. One thing I'll note that this is joint collaboration between two universities, and we have a fantastic speaker from the United States having with us with the students. It's something new, and I think this is a new norm that we're going to see in years to come, and we need to enhance this and strengthen it and look for more opportunities, especially in terms of changing of information and also maybe research collaboration later on. Right, so I wouldn't keep you long, Professor. You know, you need to get to sleep now. So with Bismillahirrahmanirrahim, I officially close this international webinar on food safety research applications to consumers and food service operators. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Thank you, Prof. Zambari, for giving the closing remarks. Well, ladies and gentlemen, that wraps up our webinar. On behalf of the entire committee members of the International Webinar on Food Safety Research, Applications to Consumers to Food and Food Service Operators, we would like to thank you, Dr. Prof. Arendt, for your insightful presentations and your time to present in this webinar. Thank you again. To all attendees, don't forget to scan the QR code shown on the screen and fill up attendance form. We will provide e-certification as a token of appreciation for participating in the webinar. It has been a pleasure to host this webinar, and we wish all a pleasant day. Thank you.
To all audiences from University Technology Mara and University Putra Malaysia, you can scan the QR code shown on the screen and fill out the e-attendance form. We will register the training hours for you. Thank you for participating in this webinar. Hope to see you again in the next webinar. Stay safe and stay well.